Welcome to The Patient Physician, a space for doctors to explore their physical, mental, and financial wellness. Your peers and industry leaders will destigmatize institutional perceptions while redefining success, money, and personal care. Get ready to pull back the curtain because here, you are both patient and physician.
Hello and welcome to The Patient Physician. I'm Paul Smith and I'm joined today by my co-host Chris Fullbright. Hey Chris, how are you?
I am great, Paul. Dr. Sexton, we are super excited to visit with you some more today.
I appreciate the opportunity to chat with you guys.
We are joined today by Dr. Michelle Sexton. She's a native Texan. Whoop, whoop. So shout out to all our native Texans out there in California. She's practicing medicine in San Diego, though, began her career as a midwife in Texas. She's currently an assistant adjunct professor in the Department of Anesthesiology at the University of California, San Diego. She's a physician, scientist with extensive clinical experience in basic translational and clinical research. Dr. Sexton's clinical research and focus on mind-body healing has been helping her patients fine-tune their endocannabinoid system since 2008. Dr. Sexton enjoys surfing, swimming, neither of which she did coming into today's session. She didn't surf or swim into this session. Gardening, guitar playing, giving back to the community, enjoying time with her grandkids, and just enjoying life in her spare time. So welcome and thank you for taking time out of all those fun activities to join us in this show today.
Thank you. I consider myself a Tex-pat.
Ah, that's a pretty good term.
Well, Texas always wants you back, right? So whenever you're ready. Thanks again for your time. I think for this conversation, what I would like to do, because I have so little information on it, is maybe just start at the top. Because relatively speaking to traditional medicine and research in the healthcare, the endocannabinoid systems really is fairly new. And so can you just, from a high level, walk us through what that is and you know where it's at in terms of some research? I know there's a lot more to go to, but just for a lot of us who are just really coming into this with very low understanding of it.
Well, the endocannabinoid system, of course, was named after cannabis, similar to our opioidergic system, after the discovery of THC, and that it specifically was binding to protein receptors in the body. So unfolding, similarly to that of the opioid system. Subsequently, endogenous compounds were found for these receptors. These are lipid signaling agents made on demand. So they're considered lipid transmitters, but not stored like other neurotransmitters. And in general, it's a complete biochemical system and expressed in, as far as we know, every tissue across the human body. And I think of it as a survival-based system for a lot of different reasons, and one that makes it interesting to sort of use as a template for addressing whole person health, since it is operating as a homeostatic system for other hormonal or signaling systems across tissues.
I am glad there are people like you, because when you talk like that, it just tells me all of that stuff is just so high. Even that, I said high level. But, a big part to me is that there has been this evolution of medicine in this area. And so you are a naturopathic physician versus an MD and DO. And so can you tell me what it was like to go through that process? Because really, if I'm wrong on the dates, I think 1988 was the discovery of the endocannabinoid system, right? So does that sound right to you? And you came along 20 years later and really specializing in doing this. What has it been like to work in that area?
Well, it was fascinating. It was not something that I specifically set out to do. I was interested in research around inflammation in the brain and had looked at a different protein receptor. And when I got to naturopathic medical school, I wanted to continue research. I really liked that process, and serendipitously got affiliated with a researcher at the University of Washington. And that was when I first started medical school. I got a training grant in 2004 And I started working in his lab and started learning about the role of this endocannabinoid system in neuroinflammation, neurodegeneration. That's what we were specifically looking at. So that opened up the door for looking at specifically the cannabinoid 2 receptor, which is primarily expressed on immune cells and immune tissues. So this was like, before this had become even a hot topic in terms of medical cannabis use. So it was really at the ground floor of starting to explore all of that.
I'm going to ask this as a question. It's more of a statement. Do you find that there's stigma around the way that you're practicing as a naturopathic doctor versus going the MD route and that training process? Because we know that the processes are different in terms of how you get there. What took you this way? You said it wasn't the way you were originally planning to go. What took you this direction?
To naturopathic medical school specifically? Mm-hmm. Well, it was probably that my background had been as a midwife and an herbalist. And so I just had a very strong sense of nature as a part of medicine. And my uncle, he was a thoracic surgeon, a transplant surgeon. And when I told him I was going to medical school, he said, well, why don't you just go to regular medical school? And I said, well, because the way I wanted to practice wasn't being taught in that system. I wanted to be able to, address the whole person and really incorporate prevention, lifestyle medicine, natural approaches that people, seemed to me to be looking for, especially in West Texas where I was. And, there were no integrative practitioners at that time. I think there was one DO that everybody went to that was more open-minded. So I just saw a need, for expertise in that area. And that's how I ended up going to naturopathic medical school.
Have you seen it grow in the way that maybe you would hope? Obviously, you've been practicing in this field for quite some time, so you've gotten to see the transition and changes. Is it growing in the way that you'd like to see it grow? And what more can we do?
We know it's different in every state. I mean, there are many states where naturopathic doctors are still not licensed, such as in Texas. Where I first practiced in Washington, we as NDs were fully integrated into the healthcare system. So patients could choose us as primary care providers. We had complete prescriptive authority, so that we could act as primary care providers. And then I moved to California, where I have no prescriptive authority and insurance companies do not recognize us as primary care providers. So, it's highly variable. And it's changing, it's growing. I think Wisconsin, another state, just got added recently, for licensing. But every state, is setting up its own regulations around it, unfortunately.
Do you think that's related? You mentioned the insurance companies. Do you think that where that's rooted back into the insurance companies of the recognition and the abilities you have to be able to step in and partner? What do you think the driving force of that is from a state to state standpoint?
The medical associations and how much resistance they want to have to new people coming in as primary care. I mean, we have a desperate need in California for primary care providers. I suspect in Texas, New Mexico, many states. I mean, I think across the United States, we're seeing this problem. And, the Medical Association in California put up a fight against bringing nurse practitioners in to be able to operate independently as primary care providers. So I know there was resistance when we had our legislation in California, and it comes from other factions. Like, we're fully trained in osteopathic manipulation, and the chiropractors, lobbied to keep us out of being able to do high force manipulation. So, there's this idea that there's competition where, the reality is we need more care providers.
Do you feel like the patients are having to choose an either or in that situation? Or do you find people are doing both? Are they seeing you and someone else? And if they are, then how is that coordinated on the medical side?
There's a spectrum, I think we may have all encountered patients who don't want to have anything to do with conventional medicine, or maybe not. If you're an MD, you're not going to see them because they're not going to make an appointment with conventional medicine. And I feel like I get a lot of those patients. I had a patient yesterday. She has insurance. I said, "Do you have a primary care provider?" She said, "No, I don't want one. I don't want to have anything to do with that medicine. I've had my experience with that. I'm happy with you following my health. I can order lab work." I said, "Well, the instance where it could be valuable to have your primary care provider is if you need a drug for something. What if you get a severe urinary tract infection? I can't help you with that." There are urgent care centers where people can go. I just think that being anchored, with a primary care provider is important. So if I can't do that, I do encourage them to do that, but not everyone wants to do that.
Well, I know there's a need for primary care. I certainly, I've seen that my primary care has on his recording that they're closed to new patients. And anytime that you're with them, you're not getting as much time. I know as a patient, let's just talk from that level. You go in and you're thinking, like, what do I need to say? What do I want to talk about? Because I'm sort of been trained as a patient. I've got like 5 minutes here. And I don't actually place that at their fault. I think that's just the model. I think that's what has to happen to run the business efficiently. And I don't think that there's I've never met a physician who's like, "Yeah, I love the pace of seeing 30 to 45 different people a day." I just think it's the way that it is. And, it's no wonder why there's so many that are anxious jumping from person to person. But you spend a lot of time with the patients that you see. And can you just kind of walk us through what that looks like, and how are you able to do that where the rest are spending those small increments of time?
Well, our standard model in naturopathic medicine is about the patient-physician relationship. And, to develop a relationship, you've got to put time into it, right? So initial patient intake visits with naturopathic doctors, I've seen some NDs that are doing 2-hour initial visits. I do mine in 45 minutes. And I think what it allows for, that the conventional system and the reimbursement system, although, you can bill for a 60-minute visit and even add on extra time, right? It just depends on what your institution wants you to do. So my integrative medicine visits at UCSD are 45 minutes. But then you've got the pre-charting and the post-charting time. So it comes out to a 60-minute visit. But in that context, I think it allows to hear the patient's story. And, storytelling in medicine is something that's gotten a lot of attention more recently. I think that's what makes the difference for patients, if they feel heard, that they have enough time to be heard. And I get that type of feedback from patients, that they appreciate that they really got to say everything that they wanted to say.
I don't know that I've ever sat down with, outside, like for my own personal health, sat down with a physician for 45 minutes or an hour or even 2. I know that there is a segment of concierge medicine that has been fairly successful and is a good business model where they do take a lot more time. And, you said this great word, and that was relationship. I don't know that a lot of people have that. Do you like having a deeper relationship with your patients to be able to spend time with them like that?
I really do like it. And I think that came from my background as a midwife, because, that's another scenario where I was spending a lot of time with my clients. And as an example, I had a new client coming for home birth. She had 1 or 2 hospital experiences with birth, I think. And she came with her young child on her first visit. And I said, you might want to plan for some childcare during the time you're going to come for your visit, because, our appointments will be an hour long. And she just had this shocked expression on her face, because her OB-GYN visits, were literally take your blood pressure, measure the fundal height, see ya, 10 minutes. But being able to, see into a person, their relationships, how they live their lives, I think is very integral into planning health and planning treatment plans. What's going to work for people. So this particular patient came back to the next visit without her child, and I had comfortable rocking chair, and she just sat down and relaxed, and she was pleasantly surprised at the difference in the care.
What would be a normal rhythm of you staying in touch? I'm reading your book, and it's fascinating. And I remember our conversation before where you did mention, in fact, Paul had brought up that we had met with a practice manager, and in their group, it's like you need to be north of 24 meetings a day to turn a profit. For you, as you go to a 45-minute intake meeting, you're talking about nutrition and sleep and stress and other things that have gone through that hopefully we'll have time to touch on. How often are you following up with them? Is it an in-person meeting that you're doing that? Or are they filling out a form and saying, hey, based off of this, I slept 6 hours, I felt this pain in my back? Walk us through how different that relationship is.
I've never been a huge fan of very long intake forms.
Okay.
We have one at UCSD, and I despise it. It's very, very long, and not only does it take the patient a long time to fill it out, it takes me a long time to read through it. And then I have to copy and paste things into the chart. So in my private practice, I have a very short intake because
Okay.
I want to hear the patient tell me the story about their health. And so, when I'm doing the review of systems, I think that's where the opportunity and the more time allows them to say more, about each system as we go through it.
I had shared with you earlier that my mom's health issues that started diagnosed last year and we're still progressing through. And she just went to a very nationally known, probably world known organization in Atlanta for a second opinion. And so many of their questions as I visited with my mom about it was, how much are you sleeping? Can you tell us about what you're eating? Can you tell us about your fluids and your electrolytes? And it went much more, in her opinion, right? And obviously meeting with the other doctors that have been going through the chemo and different things with her through these first couple rounds. That other group that came in was a different, deeper level of questions that went past the medical stuff, at least in her opinion, right? And maybe it's just sometimes we hear things differently as we go through life. I'm fascinated, though, the time that they spent on sleep and the depth in which you go to in your book around sleep and the importance of sleep, all the way through pains in the body and giving yourself time to recover, the quality of sleep matter. I'm fascinated by that because, look, as business owners and entrepreneurs and so many of the listeners to this podcast are doctors, right? And they're notorious for very little sleep, pushing through the borders of exhaustion. Can you touch on the importance of sleep and how that impacts the body, in your opinion?
Oh, how does it not impact the body? I think is the
That's
question.
probably a better question. Yeah.
It's such a foundational health thing, our circadian function. If you think about back to embryonic development, things are happening on a schedule, right? There's genes getting turned on as the embryo's developing. And so we're on a clock system from the very beginning. And then emerging into the world and the light and dark cycle. Yeah, I just think it's foundational for health, and how many people just sort of don't know that or ignore it, staying up late and thinking if they sleep from 4 to 12 noon, that's just fine. So yeah, I think in terms of one of our naturopathic principles is to identify and treat the cause. And I can't say how many times I've had patients where when going into depth into their sleep history and their sleep habits and their sleep quality, et cetera, it turns out that, my judgment is that their sleep issue is the underlying cause of other things going on in their body.
This is an issue I struggle a lot with myself, just getting enough sleep. I'm sure I'm one of everybody, but more and more, and it seems like recently, as Chris brings it up, that conversations and this coming back to the top, getting the proper rest and sleep. Maybe it's just been there, or maybe it is. Do you feel like it's surfacing back up to the top of, hey, first we have to get the right amount of rest, and then let's start to see what happens? Or is it just sort of been there and I've tried to ignore it because I couldn't get that amount of sleep? Like Chris said, a lot of our doctors can't get that sleep anyway during their training. What am I going to do? I have to get everything done in a specific amount of time. Or is it really coming back to, wait a second, we need to be talking about this more?
I think absolutely it needs to be talked about more because, if we're talking about another naturopathic principle is prevention. And as we are moving into an era of really an epidemic of dementia and Alzheimer's disease, with the older population boom, I think teaching younger people about preventing this for themselves, especially if they're at risk. And, so protection of the brain should start at birth. And I think teenagers, don't get enough education on brain development and protecting their brains. And then you go even into young adults that continue using alcohol heavily, after their high school or college fun years and turning to alcohol use like as a means of, stress reduction and how that alcohol use can impact sleep. This is what the data is starting to really point to, is that these sleep disruptions, circadian dysfunction, inability to get adequate restorative sleep is an underlying cause of protein accumulation in the brain, So it's a central topic for our health today.
Can you walk us through a little bit of the training differences? I know that we've kind of acknowledged that there's the resistance, as you said earlier, the MD side of the medicine or the medical boards to recognize this and let you do all the same things that the traditional path would allow. What does the training look like to go the naturopathic way versus doing the traditional MD and residency?
Well, starting with our basic science training, which, I think is identical to conventional medicine, although curriculums are being redesigned these days into modules. But the basic sciences that we learn are identical to what MDs and DOs are learning. And then, where our training starts to differ is our clinical education. And in every aspect of our learning about each system, so say it's pathology, the endocrine system, it doesn't really matter where it is. Our whole curriculum is infused with bringing the whole person in to evaluating any system, because our systems are not separate from each other. I think the endocannabinoid system is a great illustration of how they're all coordinated together. So our clinical training then is more focused on lifestyle, prevention, addressing underlying causes, and focusing on the healing power of nature. And so this is, I think, what people are very interested in today. How can I naturally promote my health or address disease? And this is what we've been trained in. And we mostly, it's just like any doctor, you're going to find a wide variation in how people practice. For me, it's very evidence-based. So, there are herbs, and we know a lot more about botanical medicine and mechanisms of action, and there's been clinical trials of them. So, using a real balance of the empirical evidence plus the scientific evidence to bring patients the best care that we can. We have to do outside clinical preceptorships, outside of the clinical experience that we're getting in our school. And then, I think the problem with our acceptance into the conventional system is that we don't have the same funding for residencies that other candidates do. And so there is a real lack of residency opportunities for our graduates. And this is a real sticking point, that we haven't had residencies, and so therefore we're not prepared.
Well, that's what I was going to ask next is where is the biggest resistance coming from and friction, and what prevents the growth if this is where more and more patients are asking and trying to go? it's evidence-based, as you're saying. What is fueling this friction to keep it from growing?
I wish I had an answer to that. I mean, I think, if you go back to sort of the origins of our medicine, these were the eclectic physicians. And I guess they were called eclectic because, they were sticking more with natural approaches to health rather than thinking that synthetic compounds, well, at that time, there weren't a lot of synthetic compounds coming on, but just, isolating individual compounds as medicine was becoming more of a standard. And I mean, there are historical reports that, the Medical Association went to great lengths to shove the eclectics out and shut all of that down. And I think it's still going on today. I've never understood it. I was a midwife in Texas. That's how I started my career. And, the resistance to midwifery was huge. And I just couldn't understand it because it wasn't like there was competition. I mean, we were attending maybe 1% to 2% of the births in the state, so it's not like women were flocking to this care. And we had a great safety record. Midwifery has a lower cesarean rate with better outcomes than traditional OBGYN care. So it's always been an enigma to me why natural approaches are so stigmatized and thought to be just out there or woo-woo or not valid.
Mm-hmm. My fear is that, and this is just a wild throwaway out there, is that it has something to do with what you said earlier, which was this perception of competition rather than sort of trying to put the patient first, is that if this person also can help in this way that I'm not familiar with, but I've gone and done all this training. It happens in our world of working with finance and helping clients. There's not one way to get them to their goals. There's the ways that you learn, and then there's other ways. These pathways, everybody has their fear of being obsolete. Well, rather than working together to build a cohesiveness around treatment, it seems like. I love seeing all the different subspecialties that come in, and we've seen that, gosh, even in my short time in working with physicians, we've seen they can't just do their regular residency. They have to go on to another fellowship, and then sometimes a fellowship after that, and more training. And because these areas of medicine are becoming so subspecialized, but also fractioned. And it reminds me of thinking about if you have top secret clearance. Well, but then there's top secret compartmentalized clearance, right? So you don't even really get to know all the information of the secret mission that you're doing. You're just doing that one little part. Well, who actually gets to know what the real mission is all about? And that sort of seems like the case. Like, what are we all doing here? Who's going to bring that back together to put the whole treatment together, if you will? If there's all these something which are needed and important, because that dedication to time to really understanding that subspecialty is great. Who then bubbles that back up to bring it all back together through that holistic approach to ask about starting from the top at sleep?
Yeah, that's such a great point. I think I've witnessed that, in my position at UCSD, now being in a conventional system, this fragmentation of care and lack of continuity of care. And I see things just getting overlooked, like abnormal lab results that have come back that the doctor who ordered them never addressed, maybe anemia, maybe it was mild anemia, but it's not addressed, right? And so I think for me, I have more time to review the patient chart because I'm not doing, 8-hour shifts all day, every day. And so I'm very interested in digging into looking at all of these specialists that they saw. So I'm getting this whole person picture. And at UCSD, there was some resistance to bringing an ND on as a clinician. And interestingly, one person who was very outspoken and vocal about it recently emailed me asking for advice for a friend of his. What may be happening is that I think some of the most difficult patients get referred to me because I think, neurology or pain division or geriatrics, that they don't know what to do anymore with this patient. They're out of tools in their toolkit. So they're very complex patients. And I think they come and they have this visit where we talk about everything. We talk about the whole person and all these aspects of their house and bringing it together. And I think they're going back maybe to their primary care providers or referring doctor and reporting what a great visit this was for them. And then, my referrals increase because the doctors are hearing, hey, the patient really liked this. It's a value added bonus for the patients, in this system.
Yeah, it's funny to me in your book, you just brought up the pain medicine. And in the book, if I remember correctly, you were referred to a woman from a pain specialist and you asked about the pain. She's like, oh, I'm not in pain. And you had to dive deeper and ask that next layer. And if you only had 2 or 3 minutes with her, you would have probably moved on to the next subject. But I could almost, now that I've spoken to you a couple of times, I could almost envision you taking a deep breath, letting her, that proverbial rocking chair, to get to know who she was. I think with the speed in which we have to move in other sides of the mess, I'm not saying it's bad. Goodness gracious, we love physicians to be able to care for us and be there. But there is something special about taking the time to get to know the person. And the thing that I've enjoyed about getting to know you and reading your book and going through your website is the whole person. And not, I'm going to prescribe this for your shoulder. Come back and see me in 30 days. We'll see if I need to change your medicine or you'll do rehab. But to understand, how does all of it fit together for that person individually? I think that's what healing is supposed to be about, right?
All these wonderful doctors. I don't know that it really matters the background. I don't think they want to run at this pace. It's exhausting. And I think that maybe actually having a deeper patient-physician relationship would be healthy for them too, because then we're not just, I don't want to say numbers, but you know what I mean. We're just another, next. I just don't know how do you slow that down, or how do you allow them to even have that when the reality is, again, it's a business model. It has to be that way. I think they choose that. You have to just run them through. But there's another issue to slowing down. Let's just say that in a perfect world was possible. Who can see all the patients for that amount of time? There's not enough out there now to take 5 minutes. We just talked about that. And my primary care is book of business closed. And I'm sure he's got 2,000-3,000 or more patients. So even if they could take more time, then it creates this overflow of, when am I going to be able to ever be seen?
That's a great point. Yeah. I don't know, maybe that's where, for instance, our Center for Integrative Medicine comes in, just to be able to hit all the necessary points, for instance, for primary care. You got the vaccines. Have you had all the screenings? I mean, that's what primary care is about, right? And then, I'm going to refer you out for anything else you need. So, having more integrative medicine departments where people can be referred for that care, and that people understand they're just not going to get that, in the course of their conventional medical visit. I don't think that most patients understand the brevity, and that the institution has defined how long that visit can be. Very disappointing for patients to learn. They want to think that, this is really about them. Medical care is about them getting their needs met. And I just see it not happening a lot. But despite the fact that this is the time we spend with patients in integrative medicine, the business model is we're making money in the system. It's not losing money for the institution to do this. There are, additional add-on codes. If you're doing hands-on, manual therapy, we incorporate that through osteopathic manipulation and massage therapy, but also doctors that are also doing acupuncture, there's add-on codes, right? And so that helps the business model. I think patients don't think of healthcare as a business,
Yeah.
It's a pharmaceutical industrial complex, and that's what it is. And I think more people are realizing that, and this maybe is what, is turning people away from it, the whole big anti-corporation movement out there.
When you have patients that have been referred to you and you feel like, you mentioned earlier, you feel like that they've kind of come to you because they were maybe at the end, or the person they were seeing kind of felt like they couldn't help any further. Have there been examples where you have been able to impact that patient because you were able to slow down and take the time to really look at the full picture?
I think the answer is absolutely to that. And one area that I want to highlight is having the time to look into the patient's, background and history, social history, family history, specifically with regard to adverse childhood experiences. And, this is not something that even our family medicine department routinely screens for. And I haven't analyzed the data on this. I'm just speaking from a clinical perspective. But I would say overwhelmingly, these most difficult and complex patients are having significant scores on just the basic 10 things that are looked at and for adverse childhood experiences. And so that as an underlying cause of, their disease or diseases and their dis-ease, mental health is highly overlooked and something that needs to be addressed. And yet, say I identify this, I document it in the chart, we do their scoring, I educate them about this role in their health and how it brought them to where they are today. What next? We don't have trained trauma therapists at UCSD to refer them to. We can't even hardly get them in to see a psychologist. The visits are 6 months out.
Mm-hmm.
On the one hand, it's good to provide this education, but the follow-up care is really lacking for it. But I think that type of care could really change the trajectory of the patient's health going forward.
So what you're saying, in another way to word that, is that you're finding now that if you spend enough time, that the suppression of childhood experiences, probably relative to trauma, are starting to rear their head in adulting, and that they are contributing factors and just have not ever been addressed. And who has the time to?
Absolutely. I mean, the data's there, the risk factors. If you have a score of 4 or greater on just the basic adverse childhood experiences scoring, I think there's like a 30% increase that person may have a suicide attempt. They're at risk for addiction. They're at risk for cardiovascular disease, metabolic disease, kidney disease, cancer. So, there you have it. The data is there and strongly supports all of that.
What scoring are you referring to? You said there was a 10 question or a scoring system. Is that something that anybody can access, or something that you specifically administer?
Anyone can access it. I mean, we have specific training in California on adverse childhood experiences, how to work with people with trauma medically, how to just even approach them. I think that a lot of these people are the same people who don't want to see conventional medical doctors. They cannot trust anyone with their health. These are people taking their health into their own hands. They're very skeptical of medical care. And I think this is one reason they may come to naturopathic doctors more often, that they want to have some sort of trust that nature and being natural is going to help them heal. It's a fascinating thing to look at, especially with mental health diagnoses. I can't tell you how many young women with bipolar disorder I've had referred to me that scored 8 or 10 on the ACEs scale. But I think probably most states have some sort of training for doctors. I mean, I can code for it. Medi-Cal in California will reimburse a visit for just doing the ACEs screening. So if you put the code in, it's another reimbursement code for screening.
Is there a slight suggestion that there's a declining level of trust with doctors from patients?
I just think it's highly variable. I mean, my perspective is that, but those are the patients I'm getting, I think,
I'm asking that because as you're saying that, explaining it, I'm actually going through and thinking, okay, have I gone into an office and said, what do I need to say in that time frame we talked about is small? And then what am I willing to say? Because I'm sort of governing, I don't know this person I'm talking to. Maybe it is I've been referred out. I don't have a relationship. And how vital is that to me then having that trust? It's not that I don't trust this person. I don't know them. And how am I going to get to know them in a short period of time, much less extend them my trust? I get that they're highly qualified, brilliant people. And many of them amazing, great personalities, by the way, but you're never going to get any of that out of the limited amount of time we get to visit with them. So as a patient, how do we just go in and say, okay, let me just throw all this up on you and trust that we're going to get the right information back? I think it's hard to want to be able to do that sometimes. I'm just saying from my perspective, what can I tell them? I'm nervous. Because I don't know that I trust the thoughts in my own head sometimes. Like, is that accurate? How do I know what is something I should be, that's a problem or it's not? And I think that time you're talking about is critical. I just don't know how to answer coming up with it for the patient or the physician.
And you asked earlier about, follow-up. That first visit is just needed to try to establish some trust with the patient. And it does require the follow-up and time and the relationship development to really learn more. Yeah, people may not want to come in and tell you on the first visit that they're drinking 10 alcoholic drinks a night, I had a patient one time that I was seeing her for some pain, and this was, for medical cannabis up in Washington State. And I saw her over a couple of years, I guess. And, it wasn't until I had been seeing her for a while that it suddenly became apparent to me that she was a hoarder. And she also told me that she made her own wine. She was an alcoholic, but this took a long time for me to be able to see these things about her. So, people they're not going to walk in and tell you, oh, I'm a hoarder, Mm-hmm. And so, really understanding the depth of her mental health stuff. Well, where did that come from? It turns out she had a very abusive mother, So, yeah, it's just like any relationship. You have to have that time.
And that's to the whole point what I was trying to get at is that in this situation, it's not even the physician's fault. Forget about the time. It's not their fault if there's some sort of like misstep on, well, this is what I thought would be the right treatment. You didn't get the right information from the patient. It's their fault because I didn't pony up the correct, truthful, actual information, the right numbers. I mean, we've all seen those. How much do you drink? 2 times, 3 times. I mean, there must be somewhere behind the scenes where people go, okay, well, that's times 1.3 or 1.5. We know it's more. If somebody admits to 2 times a day or 3 drinks a day, it's really more. Or I don't know, maybe there's a formula y'all have figured out to really understand what usage looks like. But creating the relationship on the front end and spending time, how else are we going to get the right information to be able to diagnose the patients properly?
I think it's, asking the right questions for one thing.
Yeah.
And then, I love asking leading questions, like a patient will say something that kind of gets my attention and then just be able to have time to say, tell me more about that. And what do they come up with when you ask that kind of question, an open-ended question like that, instead of, do you have pain here?
Mm-hmm. As a naturopathic physician, you're in a smaller number. So what would you want to convey to the traditional practicing MDs or DOs? What would you want them to be able to hear from you or take away from our conversation?
I would want them to not shy away from patients that are getting care outside of conventional medicine, to be open-minded. Mm-hmm. I mean, I'm sure it happens on both sides. I hear of horrible things that patients experience with MDs and conventional care, and I'm sure there are stories of, mistakes or horrible things that MDs think are horrible that, NDs or other integrative medicine doctors are doing. And I always just try to look at the patient, and I always believe the patient. If the patient tells me something works, even if the evidence doesn't support it, I'm not going to say, oh, no, it doesn't. That doesn't help you. Or how could that help you? Just hearing the patient and believing them is important. So if they come and they say, I'm getting help over here, yeah, believe it. It's the patient report. It's patient reported outcomes. We don't care enough about those patient reported outcomes, their quality of life. And that's what it all boils down to, is what is our quality of life?
Your book focuses on the keys to whole body wellness: eat, sleep, relax, protect, forget, and our body's system responsible for regulating it. What was your favorite part of this book that you enjoyed writing or expressing?
The favorite part. Well, I think my favorite section was the forget section, just because I love the brain and its complexity and that we don't have it all figured out. But how important it is. And not only the brain, but there's other aspects of our health that should be forgotten, like inflammation. That needs to be forgotten. It needs to serve its purpose and then go away. So I think the favorite part was just, for me, pulling together, I would say, the entire trajectory of my healthcare experience, beginning as a childbirth educator, a midwife, an herbalist, and then naturopathic medical school, that I was able to bring this all together. And it's sort of like the culmination of my whole, what I defined as what I wanted to do in life when I was 17 years old. I knew I wanted to serve women. And to be able to look back and say, I hope that I did that. And here's how, women everywhere can access that. That was my favorite part.
Well, your book is available on Amazon. Eat, Sleep, Relax, Protect, Forget, and it's out and available. So what's next? Are you working on another book? Are you doing more research? What can we expect to see from you coming in the next few years?
I do want to write another book, but it's going to be more of a historical fiction. But whether or not it takes a lot of time, to write a book, and I don't know if I'll have time for that until retirement. Right now, I'm just going to continue seeing patients. I really love the patient-doctor relationship. For me, it's what keeps me going, is having these personal encounters with people and feeling like I have done something meaningful for them, even if it was just to be a good listener. I am going to submit a proposal in the next month to study a minor cannabinoid and its effect on interstitial cystitis and bladder pain syndrome. So, to continue exploring how natural medicine can impact wellness, and doing this sort of as a bridge in the conventional medical system is what I'm going to keep doing.
And wellness is a big word. It's something that I know that both sides are really focused on. Doesn't matter your training path. So it just continues. What does wellness really look like, and how do we obtain it, both as patients, physicians, just as people? How do we achieve that in the world today? I want to thank you again for your time today, and wrap up. The show is called The Patient Physician. What does that mean to you when you hear the patient physician?
Well, I'm not sure what you intended by it. I didn't know if it meant that physicians need patients. Physicians need to also be patients, because I see people all the time in the wellness field that think they're all well, and just because you're a doctor doesn't mean you have whole health necessarily, especially working in the system, the stress of it, of just getting the charting done and showing up every day. And yeah, it's hard to be a good listener. It's exhausting. So, how can the physician also be a patient? I don't know. What was your intention in the name? I'm curious about that.
I think our intention in the name was to create thought and to have our physicians start to consider themselves and have them, that they've been in this mode for so long, training so deep in this vat of knowledge to really understand healthcare and taking care of somebody else, that a lot of that is, let's destigmatize and also put priority back on yourself, just like you said. So being the patient yourself, but it does take on a lot of different meanings. For us, doing this and having this show is centered around trying to give that focus and attention to say, hey, let's try to also turn that scope back inwards and start to see how can we care better for ourselves. And a lot of times, if we can know how to better care for ourselves, that experience and will translate and ripple out to the patients that we care for.
Yeah. I think to show up as a healthy person, and to be able to project that to the patient would make us believable, and they might want to follow our advice.
Exactly. Well, I look forward to seeing what you do next and how you continue to carve the path in this area of medicine and helping patients. Thanks again for your time today.
Well, thank you for having me. I really enjoyed speaking with you guys.
Thanks, Dr. Sexton.
This conversation was brought to you by Physicians Resource Services, a firm supporting medical professionals to improve their financial situation and pursue their personal and professional goals. The Patient Physician is produced in Austin, Texas. Editing and sound design are in the hands of the PodConnects Podcast Network. Please email questions or show ideas to info@physiciansrs.com.